either trainee nurses and then fully fledged nurses at band 5. And we'd like to bring a business case and just map out for you how that would work. We're doing a lot of the discovery work on that at the moment, making use of some of the work that Y Valley have been doing with their nurse cohorts there. So I'm hoping to bring that to you in the new year, but I do want to make sure it comes alongside some of the other financial strategies that we'll have in the next year's planning. And then Simon mentioned the medical school at the beginning of his piece, and it was brought out in the report. We've been having some brilliant conversations with Worcester University about how we can make the best of the opportunity that we've got by having the medical school on our doorstep. We know we're getting 50 places next year for the medical school, and we want to make sure that we're really capitalising on that, and we've got the training capacity ready to go for that year and future cohorts. So really good relationships with the university, and the summit that we held the other day was really positive and gave us the mandate to keep working on that and look for other ways to capitalise. And then I just want to say something quickly on reform. As I said, workforce supply sometimes is a good reason to reform how we work, because we just can't get the supply for some types of workforce, or it takes too long to grow it. There are other reasons for reforming our services around digital reform or improving the patient experience. But what we're doing, where we know workforce is a significant factor, is bringing together multidisciplinary teams and talking through that service and how to look at it differently and use different sets of workforce to try and support the service. And we're doing that using a workforce planning tool. And that's had some success. We've put some advanced clinical practitioners in place in areas that were really fragile to alleviate some of the pressure on locums and consultants, and try and take out some of the more expensive locums actually for the from agency expenditure. Excuse me. So we've got strands of work through all of those pieces, all of those 4 blocks on the strategy. This is all governed through the People Board. It comes up through the QRD, and that's obviously chaired by Vicky. And we will want to bring that more regularly to you in the board, if that's okay, through that route. And also, the NHS elements of the People Plan will be governed through the Regional People Board, which the People Board also reports into. So the long-term workforce plan elements for the NHS will be governed there, and we will make sure that we're feeding back up into that section, so we're part of that national picture. So I think that probably covers the key things I wanted to pull out for you. I suppose my asks of the board today are to note the progress that we're making and the infrastructure that we've put in place, to be ready for that business case when we bring it, because it will be the first sort of seminal thing I think that we will want to do that shows how we're growing our own and puts a real programme of activity in place for that. And then I'd like to regularly update you on some of the progress we're making where it makes sense to in a deep dive. Thank you.
Thank you very much, Katie, really helpful. Recognising that we've got temporary staffing report later in the agenda, let's leave any questions about agency and bank and temporary staffing for that discussion. But if you've got any questions about the broader sort of more strategic themes in Katie's report, this is the opportunity. So first of all, Nigel, please.
Yeah, just a quick one about the medical school, which is, as you say, is a great opportunity. I just wonder whether we're maximising, we locally in Hereford have been for a number of years now utilising medical students, training them as HCAs and using them in the holidays to backfill our staff. And I just wonder whether there is something about formalising that a little bit or making that more of an option, because they are available when our staff are going on holiday at Christmas and in the summer holidays. And they are very willing to learn. They do phlebotomy. They're good, intelligent people to have in practices, and it gets them into our practice. It gets them into our system, which I think is really, really valuable. So I just wondered whether there was any work going on to try and facilitate making sure that they feel part of our health system.
Yes, we've got a really close relationship with the university, and the Pro-Vice Chancellor chairs our Academy Steering Group, which oversees all of the different functional groups across the system in terms of the workforce needs. So we're having quite a lot of those sorts of conversations. I haven't specifically heard that one, Nigel, and I will pick that up. but we're having conversations about how to make more use of students who want to come and join the system, even business students, for example, coming and helping with theses and dissertations, etc., where we might want a specific health education piece of work done or something in the social care sector. We're looking at whether we can join forces with people, because it offers them an opportunity to join us and work with us for a bit, and gives them that experience. So those sorts of conversations are all taking place.
Thank you, Katie. Thank you, Nigel. Anna?
Thank you, Krishni. Katie, yeah, thanks for this. This is really helpful. I think the strategies you're adopting are the right ones. I just wanted just a comment I wanted to make more than a question. It's just around the grow our own strategy. I think making sure that the workplace culture, that, you know, people feel part of the system is going to be really important. Otherwise you might run the risk of losing them to other systems. So I think I wanted to make that point. So, and it's something that Nigel said, and it's something that we see with our, you know, I work at Aston, we see with our medical students, if they don't have a good placement, they don't feel part of the system, they go elsewhere. So it was just really to kind of flag that.
Completely agree. It was part of the conversation we were having with the CMOs and the CEOs at the summit. Actually, it was about the quality of the placement experience. We've got, through the HRD network and also Kim Sales, who I've asked to have a closer look at some of the culture work and the staff survey work. We're going to get more under the skin of what we're seeing with regards to placement experience across the organisations, what staff surveys are saying, and therefore where we're targeting bits of kind of organisational development work to make those experiences better, because we recognise it's, you know, it's a leaky bucket if you don't deal with the retention issue, and we can do as much recruitment and outreach as we want, but if people keep moving on, we're left with the same problem.
Yeah, thank you. It's a really important point, isn't it? And actually, I saw a really good example. I attended recently in another guise a medical educators conference, and it was actually it was all of the sort of consultants in the workplace who support medical placements and try and create a positive experience for placement for students, for junior doctors, etc. It was really invigorating, because actually it was great to see quite a big group of consultants talking about, you know, how do we create the best work experience for people so they actually can't want to come back and work for us, and everything. It was about how you give feedback, how you to create an inclusive culture. It was really really positive to see, so I think perhaps thinking about that sort of thing and engaging our workforce in what we can do to create that kind of experience for people is a really important part of, I think, the future, really. David Whiteman.
Yeah, thanks, Krishni, and Katie, thanks for the paper. You know, I think the direction's absolutely right, and it encapsulates all the kind of key areas that we need to touch on. So, you know, fully support it. A comment and a question. First, the comment is, when we talk about reform, I think we should also be thinking about reform not just in terms of, are we short of workforce, but also bringing that further into our process in support of productivity, for example, like that. So we can be thinking of reform earlier in that kind of that ladder that you've got there as well. And the second is, as I said, a question. Is there something we can do to support social care to make it more appealing and a more appealing place for people to be moving into after education?
And yes, Katie, before you come in on that, I would just, if I may add, just so I'm sort of adding a point to what David's just said. I mean, the turnover rate for care workers is incredibly high, isn't it? I mean, 37.1% is a very stark figure. So I just wondered if I could tie the two things together, the point that David has made as well.
Yes, that's a conversation we're having with social care colleagues. The Skills for Care report talks a lot about how that goes down quite drastically once you invest in people with their care certificates, and they get sort of longer in the role and more experience and feel more valued. So there's clearly something there around investing in people and offering that longer term career trajectory. We're talking to social care colleagues about how we could do that more together, how we could make sure everybody who comes into either a healthcare support worker role or a healthcare assistant or a care worker role might get the same kind of care certificates. And then if we could make that more consistent across the system, there's more opportunity for more rotation, greater career coverage, if you like, which answers the point about feeling like more of the system, but also I think helps with the retention and the investment in people elements too.
Yeah, that I think that sounds like a really great ambition, and I'm sure something that we would all want to support. Perhaps time is to bring in Paul Walker following that conversation. Paul.
Yeah, thanks, Christine. And I think that last point just kind of leads nicely into what I was going to say, and I'm sure Katie probably won't be surprised. And I think it's absolutely the right direction and the right strategy. And I think the system is the kind of the way forward here, not just only the kind of the wider health system, but the public sector system.
Yeah.
And all the advantages we talked around in terms of recruitment across the public sector, and how the leadership that's needed to make that happen, and the collaboration that we're bringing together to make that happen, for all the good reasons around kind of a single recruitment approach, telling a single story about Herefordshire and why Herefordshire is a great place to work and visit. And then from a wider kind of recruitment perspective, let's have the one Herefordshire induction programme. So it doesn't matter whether you work in health, police, fire, the community and voluntary sector, or health. We're all in, we go through the same induction process around the Herefordshire story and the one Herefordshire story. And then dare we think, stretch our minds to across the public sector, that we might even allow service to count. We might even look at secondments across the sector. So I think there's huge opportunities, which is all about a stronger, more progressive and more strategic employer offer. And I think it's the employer offer here, which is the really strong hook. So we can kind of retain more of those staff we've invested in, and then also attract the very best to Herefordshire. So whatever we can do to help play our part. I know, Katie, we know we've done some thinking here and we've got something to bring to the table, but I think there's a really strong opportunity to address a significant challenge that we all face.
I absolutely agree with that. I think that's completely the right aspiration, Paul, and our teams are talking and working together on it, aren't they? And actually a thank you to you, because the Herefordshire fair that we ran last week was done with Tracy. You put on the venue, didn't you? We had a range of partners there. Our October fair, we had the police there, we had the army there, we had a number of other public sector employers present. So I think we're feeling our way into that. There are myriad issues around employer sort of status, systems, processes that we need to pick our way through together, but that shouldn't put us off the aspiration, because I think it's the right one.
Yeah,
great, thank you.
Yeah, absolutely. And great to hear, Katie, about the recruitment fair and how that sort of came into being. Final couple of comments then, firstly from Vicky and then Russell. Vicky first.
I think just to thank you, Katie, because I think the report and your overview shows the really positive work that's going on across the system. But I think also to thank you for the increased focus on resource, as in the QRD resource element of the committee, because actually that increase in look on the work streams that you're undertaking across the system and the outcomes, importantly, is really important for us to make sure we're working to our terms of reference. So I just thank you for that work, and anticipate obviously more as we go through. So thank you very much.
Thank you, Vicky. Russell?
Katie, I would just leave the thought, we don't talk about our pensions enough. NEDs don't get a pension, an NHS pension, I hasten to add, for members of the public who are watching this. But the NHS pension is phenomenally attractive and generous. And it always amazes me, for example, Paul was talking about social care earlier. If they're lucky, they'll get a 3% employer contribution. The NHS employer contribution is well over 20%. We never talk about reasons to join the NHS being about pension. And I think we are really, really missing a trick. So if I can just leave you with that thought, I know when you're young, you're not bothered about pensions. I was exactly the same. When you get older, you realise the importance of them. But the NHS pension is extraordinarily generous. And maybe it's because people in the NHS don't realise how extraordinarily generous it is. They don't talk about it, but it is extraordinarily generous. Let's make that part of the reason to join the NHS or the public sector.
Can I just come back in on that one briefly?
Of course, please
Thank
do,
you.
Katie.
I met with the HRDs recently because we've been looking at our back office functions and how we can do more better together. And one of the areas is around recruitment and how we attract into the NHS. So this is obviously an NHS specific conversation for that element, but we were talking about exactly that and how we can be more verbal, I suppose, about the benefits and the attractions of the pensions. So I will make sure that that is tied in. Russell, absolutely understood.
Great.
Also, just for our general workforce, we're reminding colleagues, it never ceases to amaze me when I speak to colleagues that they don't realise how good the pension is. And, you know, they'll focus on all the negative things about working in the NHS. Let's talk about all the positive things about working in the NHS. And one of the really big positives is the pension. Thank you.
Thank you.
Thank you, Russell. Thank you. Katie, thank you for the report and update. I think it spurred a really positive conversation. I think we all recognise that workforce is a really big risk for us. Availability of workforce to support our ambitions is a really big risk for all of us collectively across the system, and therefore a continued focus on this is actually really important to us collectively. And whatever we can do together, I think that you've got the support of the board about, you know, we've heard the various comments from colleagues about the importance of us working together to try and create a kind of coherent public sector offer, or at least, you know, have an aspiration to, as far as possible, to do that. And clearly there's some good progress happening on this, which is really great to see. So thank you for the update. I think you wanted us to note the position, but you also wanted us to endorse the direction of travel. And I think we would support some regular updates. I know you're going to be providing regular updates to QRD, so I think we just need to think through how much of it we get through QRD. But I would like, I think, a regular update on progress on this to the board as well directly, and I'll discuss with Hannah how we can do that. Does that sound okay?
It's perfect. Thank you.
Great. And of course, individual business cases as needed will need to come in any case. Where appropriate to the board. So Katie, thank you to you and your small team and colleagues around the system who are working together on this, and indeed the people board for the work that's going on. So thank you very much. I'm going to just confuse us all now and bring us back round to the item that I ignored earlier, which was the committee escalation and assurance reports before we break. So that's item number 9. Clearly this is a collection of reports from all our committees. So I'll just bring Hannah in first and foremost. Hannah, if you want to say anything, and then invite committee chairs to raise their hands if they want to highlight a specific point from their committee. So first of all, Hannah, anything you want to say?
Okay, thank you. So we've had a busy activity over the last few weeks. So you will see numerous reports from the individual committees. Hopefully you're fairly familiar with the format of the report now, alerting, advising and assuring on the individual elements of each committee's activities. So it's nothing further to say. I think it's quite a comprehensive report, unless the chairs want to come in and specifically pull out any specifics in relation to the information contained there.
So any chairs would like to come in to highlight anything from their report or raise any issues? Vicky, please.
I think it's only just to say, Krishni, that we had a really helpful deep dive, if you like, into the winter plan that Mary presented for all board members, but we'd started with that conversation in QID. It obviously isn't in the report because it wasn't in committee, but it's just to add that because that was a really helpful session, so thank you.
Yes, indeed it was, and I was able to join that too, and thank you to Mary and the team, because it was a really helpful to understand our approach and some quite exciting developments to look forward to over winter, albeit some risks. I think, Mary, you were saying around, obviously we need to make sure they're properly resourced as well, but a very useful discussion. David, please. David.
Yeah. Thanks, Krishni. Just to point out on the Appointments and Remuneration Committee report that we say that the committee approved the cost of living pay increase to be implemented on receipt of a confirmatory letter from NHSE, and just to say that letter now has been received and therefore that increase is now being actioned.
Thank you, David. Yeah, useful to note, I think, because that has since come in. A couple of questions, if I may, and it may be, I don't know whether committee chairs will want to respond to this, or in fact, maybe, Mary, you'll want to cover it in the report that follows anyway. But there was some, I think, a reference to the MAID learning at the MAID event, and I think, you know, in the context of everything we've been talking about in trying to make sure discharges happen in a timely way, I assume that's was quite useful and important. I just wondered about learning from that and how that's being fed into our plans.
Thank you. I'm happy to come in there. So this is Worcestershire based, a multi-agency discharge event, a really well organised one this time across the whole system. Lots of key people in the trust going patient by patient with the teams. A lot of learning, and the trust will say themselves for themselves to implement, to improve processes and particularly speed of processes. But there was some system learning as well. So some of it we knew, some of it was already in our existing plan but hadn't been fully implemented. Some of it is we've added to the urgent care recovery plan for Worcester to try to deliver at more pace. What is pleasing though, we have now set up a series of MAID events over the winter, something that is best practice and does actually really work very well. And we will see the outcomes and hopefully get better flow as a result of this over winter than we've had previous winters.
Thank you, Mary. That's really helpful. The other area that I thought was quite useful that it was mentioned in the Mental Health Collaborative report was about most appropriate agency policy. I think it's the MAAP. And Simon, I was just conscious that this was discussed at the Health and Wellbeing Board that we were at yesterday. And I just wondered if you want to kind of comment on the discussion that took place there and how we might want to take that forward.
Yeah, happy to. And for board members' benefit, this is some national changes in police policy about the types of incidents they will respond to. And specifically, it talks about people in mental health crisis, safe and well checks that the police would have helped with previously, that they are shifting their policy not to help with and to make sure that they have policing resources available to respond to their core business. So we've been aware of this for over a year now. It was based on a pilot that happened in Humberside and some learning, and then it was decided nationally that this is something they would do. My observations are that this is being implemented quite well in Herefordshire and Worcestershire. We've had good conversations at both of the Health and Wellbeing boards with the Police and Crime Commissioner, who is clearly significantly invested within this. I think it is really important that we continue to work in partnership with the police and particularly the provider organisations. So I was in a text conversation with Sarah last night. I know she's in Liverpool at the providers conference, and there's some things we've agreed to do because specifically they're at the front end, really. Those frontline mental health workers are at the front line of this, really. Sarah's view is that actually it's been managed really, really well, but I think it's good to draw out, Krishni, that it is an issue that we as a board need to be aware of, and please be reassured that we'll kind of escalate any issues if those emerge over the coming months. But as things stand today, I'm pretty confident with where we are with this.
Thank you very much. So if there are no other comments or questions, I think we're just asked to note the report, which I think personally find really helpful and comprehensive without sort of going into too much detail. I think it finds it's a helpful level of summary of the discussions that have taken place, but of highlighting the key issues. So hopefully colleagues from a board perspective will feel that they're comfortable that the assurance has been provided that the committees are discharging their delegated responsibilities effectively, which is really the purpose of the report. So we're asked to note that and note the key decisions that were taken. And of course there is a suite of committee minutes as well for full transparency available for us to review and indeed for the public to see. So thank you everyone for those items. That's been really comprehensive coverage of a variety of items so far on our agenda. We have got time built into our agenda now for a short break. And we're right on time at the moment, so I'm hoping that we can keep that way. So if we can all be back for 11:30, we can continue with our meeting and try and conclude the rest of the items. Please remember that we are still streaming, so if you could put your camera off and microphone off temporarily and be back, as I say, to start at 11:30. Thank you. Right, welcome back everybody. I make it 11:30, so let's kick off with the next item on our agenda, which is item 12. So our deep dive on this occasion is on health inequalities, and I think we, perhaps felt that it was really important for the board to understand the work that we were doing on this. So it's not a traditional performance issue, but felt it was important that as it's one of our key responsibilities that we should focus on this. So really pleased that we were able to get this on the agenda. And David, I think you're going to perhaps kick this off and we can then have a discussion. Over to you, David.
Yes, thank you, Krishni. So a 14-page report for me. Sorry about the length of it. I'm going to start getting a reputation of writing too long reports based on today's performance. So just to re-emphasise the fact that this is as Krishni says, a statutory duty of the ICB, the 4 pillars of integrated care systems. One of them was about reducing health inequalities. So absolute sort of front and centre of everything we do. It builds on the work we did in the development session in October. It builds on work we've done through the Joint Forward Plan, the strategic choices work that we did a year ago, where we specifically talked about funding mechanisms for health inequalities, and the patient story from earlier in the day. So that's just demonstrates that this is a continuing theme for us that we're continuing to work through. So health inequalities, as a definition in the paper, they are unjust, unavoidable differences experienced by people in access, outcomes and experience. That's what they are. Some of them are caused by wider determinants such as poor quality housing, poor engagement with education, low income, or as Nigel pointed out just now, just the simple issue of trust in services. However, some are also created by the way in which services are designed that make it more difficult for some people to access. And we talked in the primary care session there about, if everything's digital only and people can't access digital services, then that can create a health inequality. If everything is designed in a particular way that doesn't meet the requirements of a particular group, then it can create a health inequality. So that's a key element as well. This report particularly tries to focus on the health inequalities that we can directly impact as NHS partners. So we can influence things like income and housing, the way we interact with partners, etc., in our work with local government colleagues and the wider groups. We can't directly control them. So I've tried to focus here on some of the things that we directly control and influence. So a couple of key messages that I wanted to sort of start the thinking with, and that's that there are some pretty clear measures on this. There's a lot of good public health data out there about health inequalities. And for us, page 3 draws out some of those kind of headline measures, which is a gap in life expectancy between the least deprived and the most deprived of around 8 years for males and around 6 years for females. But that only tells half the story, really, because if you look at healthy life expectancy and the difference between healthy life expectancy and actual life expectancy, what we see is people living about 15 to 17 years of their lives in ill health. So a fifth of people, so many people live a fifth of their lives in ill health. And that issue is exacerbated in health inequalities. So those gaps are greater in where health inequalities are greater. But beyond just deprivation, which isn't the only cause of health inequality, there are some even bigger health inequalities that are drawn out in the report. So, for example, severe mental illness, it's got a gap to the general population of 10 to 20 years. Somebody with a learning disability, a gap to the general population of 14 to 16 years. But it was the homeless one that struck me, a staggering difference of more than 40 years in life expectancy between homeless people and the general population. And the other one that struck me as well was about just the impact of health literacy and the fact that if people with poor health literacy have a 75% increase in risk of premature mortality. So some really interesting stuff that the report draws out about trying to get health literacy material down to a reading age of kind of 9 to 10 years old. So we don't make it complicated for people to access, because that in itself is one of the greatest health inequalities. So page 6 of the report identifies our spending during the course of this year. and emphasises the fact that the vast majority of our spending, and our spending in total, you know, easily identifiable spending. I mean, obviously it's not quite as simple as this, but easily identifiable spending was about £5.3 million in this area. The vast majority of that is invested in bottom-up plans developed between local communities, PCNs, local district collaboratives in Worcestershire and neighbourhoods in Herefordshire, etc. So they're really targeted on what's specific to the local community, and not the ICB saying thou shalt do the following things on health inequalities, and kind of really important part of our strategy around that. There's 3 pages detailing the kind of schemes that the PCNs are doing locally, so I won't go into those, but I think it just emphasises the kind of the importance of not having a one-size-fits-all on this. The report also talks about some of the common themes, the things that are big common issues: CVD, cancer screening, mental health, where there's a value and a benefit, smoking cessation, etc., a value and a benefit of doing things at scale. So the report talks through those. And it talks about the specific things like smoking and weight management and the like. And then the report goes on to end page 12, 13 about future plans and our intention to create a prevention and health inequality and investment standard for the coming year, so we can continue to try and ring fence some funding to invest in these very important initiatives that will have a massive impact on people's lives. Of course, we know it's difficult. The financial situation for us is very difficult. The circumstances this year that we're dealing with and the plans we're developing for next year, but it remains our intention to create that investment standard. So I won't say anything more in terms of an introduction at this point, Krishna. I'll just sort of pause and open up for questions and see where we go.
Thank you, David. There's certainly a lot of food for thought in there, and you know, evidence of things that are happening as well as sort of plans, which is really good. So any comments or questions that people would like to raise? Okay. David Whiteman first, please.
Thank you. I seem to have jumped ahead of everybody else, so I thought I pressed my button after everybody else, but mine was only to say, I think we probably all share the same feeling that these are really shocking statistics, absolutely shocking, but really welcome the initiatives, and I think there's some really good and heavyweight and strong initiatives here. So it just that general comment, but also to point out the little small focus ones as well, like the family coaching. I find those very, very positive, trying to get right to the root of issues to prevent them happening in the future. So I see a lot of prevention in here as well as addressing the key issues. So I really welcome it. So thank you, David.
Yeah. Thank you, David, for the comment. I think it is, you know, I think the point about the data and particularly the healthy life expectancy piece, I think that is, and it's getting worse, sadly. I mean, I think all the trends are going the other way now, and therefore our focus on that is so important, because it is all about then quality of people's lives. Actually, you know, longer life expectancy is only great if actually you can enjoy it and you know, benefit your family and you can benefit from it. Nigel, please.
Thanks. Yeah, no, really grateful that we've got this on our agenda. This is fundamentally really important. I had the luxury last week of attending a session with Professor Bola Olabi, the NHS lead on inequalities, and she was inspirational. She was a bit of a force of nature in driving this forward. And some of the points that she made, you know, that really none of the stuff that we know now is new, and the fact that actually the Black Report in 1979 was highlighted very many of these issues, and in fact we've made little progress, and that should sit on our shoulders. And what we mustn't do is really do the same and acknowledge the presence and not make changes and not drive this forward as a priority. So absolutely right that it's here at this board, and thanks for that. I think one of the other points that she made was, yeah, absolutely, this is a morally right thing to do. But alongside that, there is a business case for this, and that is actually the cost and the wider cost to society and the country of people who are unproductive for large numbers of years is huge. So actually, if you look at that business case, it does make sense. Now, the problem is, of course, the people who are making the interventions don't experience that financial benefit. It's experienced in other areas, but actually as a system, having our people working and engaged is actually in all our interests. And productive. So not only is there the sort of moral case, there is the business case. This makes sound sense for us to be doing this just from a business point of view. So absolutely, this is fully to be supported, and I would really welcome that we could perhaps bring this back and just check progress, and so that we don't just treat it as a report acknowledging where we are, but actually demonstrate progress. And I guess getting the right metrics for that, bearing in mind that it's going to be small numbers, they don't show up well on the big metrics that we put in for, so we just need to make sure that we've got focused metrics which are making sure that we're making a difference.
Thank you very much, Nigel. I think we'd all support what you've said there. And David, we might want to pick up through, perhaps we could come back to reporting and updates to the board, and maybe metrics linked to either our integrated care strategy or our joint forward plan, depending on which one you think is appropriate, but perhaps something to touch on. And worth mentioning, I think Professor Owolobi is visiting us next week, if I'm right. I think she's coming along to see what we're up to. And you're right, Nigel, I've heard her speak a couple of times, so she's incredibly passionate, inspirational. I think a GP by background, isn't she, as well? So really kind of inspirational, but also very close to the front line, which I think between, you know, that sense of actual personal experience of making change happen feels really powerful when those of us have been able to see her speak. So thank you, Graham.
Yep, thank you, Krishna. Yeah, like everyone else, I think I was doing double takes at a lot of these figures. They really bowled me over. The one that caught my attention really was the health literacy. 43% of working age adults don't have the literacy skills they need. And it strikes me that if we're really serious about prevention, we need some sort of connection almost into education at an early age at primary schools. You know, in a former life of mine, I used to get involved in oral health training. And just the payback from that of teaching kids how to brush their teeth properly made colossal differences. There must be so much we can do, and I don't know the extent to there's a national initiative, or we can do something in outreach into schools just to get that ball rolling.
Interesting thought, and we'll perhaps come back to that as something, because I know we've rolled it out. I've seen it being promoted for our staff, as I recall, that training, and I do wonder whether there's an opportunity to make that more widely available. But perhaps David, you can come back on that in a little bit later. Are you happy, David, if we carry on just picking up some points and then you comment, or do you want to come in periodically so that you're not having to write down too many things in one day?
I mean, I could probably tick off a couple of these things relatively quickly, and we may.
Okay. Do you want to do that then?
Conversation. So the point that Nigel talked about, reporting and updates. Yes, I mean we're constantly talking about the slow burn and the quick impact. Some of these initiatives take a long time to kick in, but some of them can be measured quite quickly. And the really good news story recently is the reductions in maternal smoking that have been recorded across our system as a result of the work that we've been doing across both maternity sites on reducing smoking. So that kind of thing is a quick impact. It's not an outcome in its own right, but the evidence shows that if you stop that, then the outcomes will follow. And that's one of the challenges around the health inequalities agenda, is linking the kind of the right interventions that the evidence shows will shift the outcomes in the long term. In terms of the engagement with schools, I think that's a really good point, actually, and it's something I think we can pick up through our two health and wellbeing boards, because obviously they have a very clear focus on bringing partners together at a place-based level to focus on improving health and wellbeing outcomes. And if health literacy and engagement with schools is one of those, that would be the best place, I would think, to pick that particular issue up.
Thank you, David. I think that's a really it's a really good point. I think that one to take forward, as you suggested. Vicky, please.
Thank you. Thank you, David, for the paper. I think what's really great about the board discussion today is the link between the patient story that we heard much earlier and then this, because we had the discussion about patient-related outcome measures and the powerful impact for one individual. But I think, you know, how it's come together to generate this passionate discussion is really helpful. So thank you for the planning, Hannah, David and Catherine, for that.
Thank you, Vicky. Paul Walker, please.
Thanks, Christine, and thanks, David. Yeah, like everybody else, quite taken aback and astounded in many respects about the powerfulness and the impact of the numbers. David, I just wanted to check in terms of how do you build on the momentum that the report is generating and the commitment to want to do things and be progressive, both strategically and tactically. I'm conscious that we have a health inequalities subgroup or working group, but you know, there's some suggestions that are coming out of today, and I think some momentum to build on that we can take back into our respective organisations. I mean, clearly for me, I want to play my part in terms of how we use schools and other locations from a place-based perspective. And I suppose it is that place-based strategic discussion happening in the health inequality subgroup, or is there something that people like me can do to help move that on?
David, do you want to come in specifically on
that?
I
mean, I think it's a really good point, and I think it's probably the critical point about shifting the dial on this issue at the moment. So back in the summer, we kind of wrote a bit of a statement about we wanted to make health inequalities everybody's business, and we submitted it as part of a plan to NHS England. What we're talking about here, and yeah, you'll know, it won't go amiss from people. We've done board development session on it. We're having a board deep dive on it today. We have the Integrated Care Partnership Assembly meeting on the 4th of October that focused in on local prevention and health inequality initiatives. So we're really trying to put it front and centre of everything we do at the moment. And what we need board members to do is go away and champion this issue in everything you do, in every conversation you have, and every opportunity you get to remind people of these kind of headline statistics. I then think, Paul, that taking it to the health and wellbeing boards and having a discussion about the, you know, how do we turbocharge and really drive this forward and get it to make sure that it is properly having an impact is probably the right way to do it. I'm a bit reluctant to have a kind of a, you know, a single across the ICS way of doing it. I would much rather that we continue to support the bottom-up initiatives and get the resources in the right place to support those to thrive. And I think the best place to start there is the PCN communities and the health and wellbeing boards.
Okay, thank you. Thank you, Paul, for the question and David's response. Aman?
I think David just partly answered my question. It was just wanted some assurance as to how we're working with community groups to really reach out to those disengaged groups, you know, people that won't have trust in the system. And I know we discussed this at a board meeting, and I think it is those communities that are going to tell us what the right things to do are. And I just want some assurance as to, you know, whether we're doing any of that.
We can absolutely do more, but the Your Health Bus and the Talk Wellbeing service in Herefordshire are the two practical and tangible things that you can see and wrap your hands around. So those are two things we're doing, but we absolutely can do and need to do more about listening to communities and building up from what they're saying. And that's why I go back to there is no one size that fits all. It's about getting the right resource and the right focus in the right area. And those areas are different across our system. So
yeah, and I think it links, doesn't it, David, to the sort of the conversation we had at the Partnership Assembly, which obviously brought members of the both health and wellbeing boards together, as well as various community representatives. And there was a really good example, wasn't there, of I'm sure we mentioned this before. I don't know whether we mentioned this before, but the football club example, football club that was providing you know, basically support for people who was sort of struggling with social isolation, of providing exercise classes, and it was just so important to the community and very much driven by the local community. And so that I think our conversation was, how do we empower and enable and get those groups working? And to be fair, I think that the local council have been really particularly effective with that, but it's how do we get all of those groups and support those groups? I think was the conversation we had that day.
And what was particularly great about that example, Christian, which I think is important to emphasise in the context we're in, it wasn't a massive financial commitment from the kind of the public sector purse to make that happen. It was about creating the environment where the football club could do what it wanted to do. There were a couple of sort of financial things that the district council did, but district councils don't have huge pots of money to invest in these things. So the fact they were able to achieve as much as they did from just being an enabling body is what really struck me about that. And I think there's a lot to learn from our district colleagues and our councils about how they achieve that.
Indeed. Thank you, David. Right, Sarah and Nigel, in that order, please. Sarah first.
Thanks. I didn't, so in no way intended to be negative, but just again I suppose in the public facing meeting, I think just for clarity really, that whilst reading the paper like this, I think is fair to say brings to the fore of our minds some of the shocking things that we see there. In no way would I want people to think that we are shocked and surprised because we did not know this information and this is the first time as a board we're seeing it, and because that is not the case. This information, as Nigel was saying, is replicated from the Black Report. We know it, and I think it's sobering to see it today, and it brings it to the fore of our mind. But I wouldn't want it to be misrepresented that as a board we were suddenly being presented with information that we had not known about before, and I think it has been influencing the drive for better work in an integrated manner across health and social care. So I just wanted to put that out there, and I think David's done a really good job of summarising in his answers the real way that this works from communities with self-identified problems and self-identified solutions and some really inspirational community leaders, all the way through primary care networks that can do huge amounts of local work, place. So Herefordshire's got its own health inequalities strategy, and then up to system. And it's trying not to boil the ocean. There is so much here that is within our control, and we must not be party to allowing ongoing, enduring, systematic failures that we can change to improve people's outcomes. And there are so many wider determinants as well that I think the comment about being able to influence, work together and champion in our day-to-day lives as well as our work lives is really vital. And a comment yesterday that was made, and when we're looking at our reporting, but at the Health and Wellbeing Board in Worcestershire yesterday, I thought quite a nice line was that lived experience is data that should be widely known. And I thought that was also really helpful, that whilst we will be able to measure some data, actually capturing people's lived experience is also really vital. Thank you.
Thank you, Sarah. It is really important about lived experience and data kind of coming together. And that's why I think the patient stories actually can be really powerful in really kind of illustrating for us the difference that services can make or haven't taken the opportunity to make in some people's lives. Yeah, I mean, the data's been around a long time. I think this is probably, I think the reason why there was genuine, I suppose, excitement about the opportunity that system working presents was this is we maybe finally have a structure that might help us to work together to address this, because in the past perhaps we've been trying to do that very much in our various silos. And frankly, I think the NHS in particular has been, perhaps too much of a treatment service and not enough, as I think we alluded to earlier, enough of focus on prevention and understanding where we can make a difference in terms of inequality. So that's the opportunity, I think, that's there in front of us. And I did want to mention also, Nigel made the point about the business case, I suppose, if I can call it that, for this. And actually one of our aims is also to make a contribution to the economy, you know, the sort of well-being and economic benefit of our community. So this ticks a number of boxes in a really positive way in terms of our duties that we have as a board. So Nigel, please.
Yeah, I just wanted to just share two bits of good practice that I've come across from elsewhere. So one of them was about, and Sarah mentioned this, really, the connecting of community leaders and representatives into the system, and it's that sort of bridge of trust. So if you look at places like Leicester, they have community connectors which provide the trust, so people do come forward for screening, do come forward because it's explained in a way they understand it through people they trust. So having that bridge of trust from the health service into those who aren't accessing our services is really important, and I think we can learn from elsewhere and develop some of those models. And the other one was one which I think I've mentioned before, was one which the local authority actually in Tower Hamlets in London used, which was they had a health star rating which they allocated to schools, and this was along the lines of, you know, did they do the Daily Mile, do they do education, do they teach about how to access health services and the importance of screening and health promotion and health prevention. And that was all put into the curriculum, and that sat along. So when they had their Ofsted, they also got the local authority 3 stars, and you know, then you were likely to be considered to be outstanding if you were ticking all those boxes. And it wasn't a mandatory thing, but all the schools complied and actually embraced it, and it really helped formalise getting a structure in. And you know, people who have had real reticence and really they had a huge turnover of population of an immigrant population which did struggle with accessing services, so it really helped. But I think that there's sort of perhaps lessons there that we could perhaps learn from.
Thank you, Nigel. It does strike me that, you know, a couple of times now we've talked about the relationship with schools and the opportunity that might present. So it feels like something we really need to explore, and it very much builds on, you know, and I suppose Katie was talking earlier about the importance of talking to schools about future employment. So it, you know, if we can start influencing our population from a young age, whether it's to come and work for us, whether it's about health literacy, all those things feel really important and ambitious, but I think it's important for us to have that aspiration. So David, if we can ask you to just think about how we kind of build that into our plan. So before I bring you back in for a final word, I think the one additional point I wanted to make, just building on something Nigel said, I really like the bridge of trust. We touched on trusted places, and I saw some really good examples during COVID which I think we really need to not lose the lessons of, because there were some really good things we learned, you know, for all the challenges and the difficulties that COVID presented. There was a lot of learning, and one example I saw was how we got, you know, how a mosque actually was able to book appointments for people to come and have their COVID vaccination. And I thought, actually, that's just so amazing. You know, it was such a kind of felt like a really small thing, but one where, because people from the community were helping people to book appointments, that sense of trust was there. And the other, you know, small things that seemed to make a difference was, I remember another example I read about, actually whilst I was judging an award. People had applied for various awards for their work, and the other one was a simple thing of GPs writing to patients in their own language, and the difference that made to people feeling like they were really included. And so when they got that letter in their own language, they actually engaged better. An evaluation project showed that. So there's so many small things that can make such a big difference. But I did also want to point to two things. One is the compounding effect. So we shouldn't forget that if you are homeless and perhaps have a learning disability, or if you're homeless and you come from an ethnic minority background, your life outcomes are probably even worse than shown in this data. So the intersectionality, I think, is really important here because it has a compounding effect on people. So we need to understand that. The only other thing I did want to mention, David, is the Jonathan Wells comment at the Worcestershire Health and Wellbeing Board yesterday about asymmetrical investment, recognising that some communities are more disadvantaged than others, and therefore, and I think we all agree that that is the case, and therefore we need to be focused on that and think about how we can evidence our ability to sort of impact more on those areas in terms of investment. So David, that's a lot to throw at you in these final few minutes of this item, but perhaps you could just close off and maybe think about what you'd like to do in terms of coming back to us to report on progress.
Yeah, thanks. I mean, I won't go through all of those points, obviously, because noticing the time that we're bang on time. A lot of stuff to take away there. Lots of teams in the ICB and beyond that I need to engage with to pick these things up. So particularly struck with the connection to schools that's come up a couple of times. So I will go away and speak to local authority colleagues about how we do that. And I like some of the specific initiatives that have been described today, which some of them are new to me. I'd not heard of them. So I'll go and make the team aware of those and do some more digging to see what we can learn, because we should steal with pride. It would be great to come back and have an ongoing conversation on this, because my absolute priority is to make health inequalities everybody's business and to keep it as a focus on all of our minds in everything we do, every day we do it. So that would be what I would love to be able to do. So.
Thank you, David. And I think we're saying, this is part of our planning process. So that's a really important message in itself. We're building in our thinking about this into our planning process so that it's inherent in our plans for the year ahead. And perhaps we should, at minimum, I think about an update in 6 months so we don't lose that sense of momentum. I'm not sure we should leave it for another year, let's say. So if people are comfortable, perhaps we can aim for that, David, and again, Hannah, you and I can just think about how best we accommodate that, and whether indeed we do that at the board or another development session. But really important for us to note the content and the progress, lots to think about and take away, and let's agree that we support the inclusion of prioritising this work in our planning process, but also a regular update to the board, format to be agreed, but that we recognise the importance of this. So thank you everyone for the contributions, and thank you to everyone who's doing the work already on this area. We know there's been a lot of work in this, but it was really important to bring it to life. So thanks very much, David, as well. Okay, we move on then to the System Quality and Delivery Report. Mary, I think that some of these things have already been highlighted, haven't they, in our assurance reports already, but if there's anything else that you want to bring to our attention, we can take that opportunity now. Over to you, Mary.
Okay, thank you. So thank you, Chair. This report is obviously designed to provide assurance in the key information of the work of the QRD and indeed across the ICS. So urgent care, I won't go into any detail. We can see we're still in a very challenged position, particularly on ambulance delays. And we've already discussed we're in the middle of implementing all our winter plans and actually communicating those plans with the frontline staff as we speak, because that's what we learned from last year. We didn't do that well enough last year, so we spent a lot of time designing and doing that this year. The one thing on urgent care I'd like to just to highlight to you is that one of the 10 national high impact actions, and something this system really does need, is a single point of access for professionals, place-based, to have one number they can phone to direct the patient to the right pathway. Looking at the work that we're doing, there is a lot of pathways, alternative pathways to the hospital, but I don't think everyone knows about them and doesn't know how to access them, or they're not easy to access. So we are, for Worcestershire, that starts on the 4th of December, and I'm aware Herefordshire are still in the final discussions about implementation. This could really revolutionise the way we flow urgent care through our system and prevent those avoidable A&E attendances that cause a lot of blockage in our ED and are not really great for our patients. So we will do a proper evaluation of it, but we'll make sure, you know, this winter it's key to getting these in place. So it's quite exciting for the staff and the system, to be honest. Okay, so elective care and diagnostics are the key issue that we look at in QRD and we oversee as a system. So elective care first. Obviously, we are aware that we were asked to put a road to zero plan in place for patients waiting over 78 weeks for elective care. That has been a challenge for us in a couple of specialties, not across the board, in a couple of specialties. We've been asked to put a revised plan in because we were unable to meet the July target for the end of November. That will still remain a challenge with just approximately over 100 patients waiting over 78 weeks, which in the size is not a massive percentage, but it's still something we're grappling with at the moment. But NHS England and the national team are pleased with our progress to date. So we have been stepped down from any tiering for elective care, which means we are now, the ICB is responsible for overseeing the improvements that we require in elective care, and we'll continue that journey where we can to get to 65 weeks at the end of the financial year. Just to note on that, we are heavily reliant on insourcing and outsourcing an independent sector, which I'm sure we'll be discussing later on the agenda as well. Some pleasing notes that you'll be aware through several committees and through the board previously of the GIRFT programme, the national programme of getting it right first time and efficiency in our elective care programmes, and Professor Tim Briggs, who came to us probably nearly 2 years ago now and helped us to develop a structured plan on how we would improve our productivity. He came back for a revisit at the end of October. He is very pleased with our progress. He's told me himself he's pleased with our progress, particularly around improvements in day case rates and increased theatre capacity in certain areas of our system. We are very clear, though, about the continued improvements that we need to make in getting it right first time, and it's really good to see the engagement across the ICS now is much improved from our early days, and we've got clinicians learning from each other and talking to each other about how we can improve things, which is helpful. Cancer, we still remain challenged in some of our cancer specialties, and this is largely due to capacity, but our particular focus is on the urology pathway that causes the biggest issue with our delays. And we are having external peer review, and we are getting as much mutual aid as possible for the diagnostic part of the pathway. We have resolved the sort of operating part of the pathway, but the diagnostic pathway still needs improvement. So we'll continue that journey to try to aim to meet our targets at the end of the year. And then our vulnerable services, which I know we've briefed you on before. I just want to give you a couple of live examples of where the ICS is working that would never have happened in previous structures of the NHS. So we have two very vulnerable pathways at the moment. One is dermatology at Worcester Acute, and the other one is orthognatics at Wye Valley. It's orthodontics plus max fax. It's a term we've all learned a lot about in the last few months. We have got an agreement now that that Wye Valley will be the lead provider for dermatology, and indeed the work is going on now for them to be the lead provider for the ICS. And on the opposite, Worcester Acute will be the lead provider for orthognatics, to give us that sustainable service with the right workforce in the right place and a much more cost-effective service, dare I suggest, as well. So this has really broken down the barriers of bringing the ICS together, and indeed only yesterday they came up with another pathway that we can consider that mutual aid and one lead provider. So it's really now starting to be embedded in practice, which is really, really helpful. And then finally, from our quality section, for some really pleasing news, the CQC report from the planned maternity visit into Wye Valley in June of this year has been published. Significant improvements have been made within the service, and overall it's rated good, which is really pleasing and good news for the patients of and the public of Hereford, but also for the staff in the hospitals as well. And Worcester Acute as inspection has taken place, and we await the final report from them as well. So that is particularly good news for Hereford, I would suggest. And that's all I wanted to highlight from the report. I'm happy to take any questions or comments, Krishna.
Thank you, Mary. And we should really recognise that CQC outcome for Wye Valley. I think very positive to note that, because it's in the context. I think that's a very positive achievement in the context of challenges in maternity services more generally. Any questions or comments then on the content in that? I know we picked some of these things up earlier. Just so really good, Mary, to note the kind of increasing use of the fragile services framework, or how we want to describe that. And actually, I mean, I'm perhaps precipitating the question that I was going to raise later on, but we're suggesting that the risk around fragile services and how we manage those is closed. Is that because we feel now really confident about, so I don't know whether Hannah will want to come in on there, but is that because we feel really confident that this is now working and effective, and we're really clear about it? Because the two items on the agenda seem to sort of link quite clearly for me. So Will, did you want...
Oh, sorry.
Yeah, sorry, Mary, go on.
Okay, so I think we're very confident in the process and how it's working. Getting to the outcomes is the big challenge, and making them actually sustainable. And you know, is that, and I'm sure Katie would agree with me. This isn't just about workforce. This is about the best practice pathways and changing the way we work in a more efficient way. It's probably 50-50. I'd suggest that is our challenge at the moment. So that's what we're focusing on.
So Hannah, as I say, I'm sort of precipitating the question I was going to ask earlier, but are we confident that we've got enough evidence of sort of assurance around the mechanism working that we can close that risk? Is that what we're saying?
Yeah, that's exactly it. It's kind of split into two issues, really. It's the process of identifying, and then it's obviously the individual sort of services. So yeah, no, I would absolutely agree with that.
Yeah. Okay, great, helpful, thank you. Okay, Will.
I was going to say much the same, to be honest. I think just to reiterate, our process, I think, for identifying and managing fragile services is now excellent. We've got a lot of experience of it, unfortunately, but it's now the process that's been adopted pretty much throughout the Midlands. So that's why we've kind of reduced our risk on that. That's not me to say, fragile services will always appear. Sometimes they are unpredictable, but I think we're as good as we possibly can get now at identifying them. Managing them then is a whole different, and that is a different raft of interventions dependent on what's the problem within that speciality.
Yeah, thank you, Will, really helpful. And have we got a document or something that describes what we do? Because interestingly, I'd really like to see it, not for any other reason other than I think it's been cited as good practice to other systems, but I'm not sure everybody's kind of got the same focus on it as we have had, and so it's probably one that I'd like to sort of promote, really. So if someone could send me a copy, that would be great, because I think, you know, it's certainly been mentioned. I think in Northamptonshire somebody referenced it to me and said, oh, I hear that there's some good work going on there, so it'd be good to make sure that it is widely known, the approach that we've taken. And then there was reference, I think, to GERFT actions, Mary, in a couple of the reports, that obviously discussions around the review that had been undertaken. Could you, because GERFT is to some degree kind of linked to productivity, isn't it, and utilisation and that sort of thing, and it's a really good example of sort of trying to drive improvement through data. Not that I'm kept close to it, but it's that's my sense of it. But I just wondered if you could say any more about that, Mary.
Yeah, happy to, thank you. So we have 6 main GERFT programmes across our ICS, and it's interesting you mentioned data. One of the things that Professor Briggs encouraged us to do a couple of years ago is to get very detailed dashboards, not just with data, but with analysis of the data and benchmarking against the best practice nationally. And that's been a bit of a game changer in, you know, across our system. I'd suggest particularly with the clinicians. Nothing like a bit of healthy competition, is there? It was, you know, particularly on theatre utilisation time, starting in theatres, day case rates. We've got 2 new elective hubs, or we've got one already. We've got another one starting in Hereford next year, and really it's getting us ready for how we utilise them to the best productivity, and it's taking steps out of processes that are really unnecessary and just gathered over the years to get us back to that productive way of working. So we get a lot of information from the GERF team. It's very useful. You haven't got to go and look for your own work. It's then about encouraging clinicians and managers to implement it at pace in our local area. It has been very, very helpful for us.
Great, thank you, Mary. And I also, just before we close on this, just wanted to mention that Russell has shared a view that that you know, there's been a kind of really good positive working across the 2 acutes in our system, and obviously that's really helpful, and the kind of changes that have taken place over the last few months, and learning, I think, from the fragile services issues we've had earlier in the year, all have kind of come together to improve the position. So that's really important, and most importantly, benefit to our communities. So thank you, Mary. I think you just want us to note the report and note the issues that you've highlighted in terms of performance challenges and priority areas, but also the actions that are underway, and we'll hear about those furthermore at future meetings, no doubt, because there will be the ongoing focus. So thank you, Mary. We move on then to the temporary staffing report, which we referred to earlier. And it's back to you, Katie, for that.
Thank you. So I'd like to just give you a bit of context, really, because we want to start bringing agency updates to the board on a more regular basis. But before we do that, and to make sure everybody understands the context in which we're operating, we thought it'd be useful to bring a short paper to give a bit of an overview. So agency expenditure remains a big issue across our system, and we